body's been a chessboard, making moves and losing out. Played so many times before, and there ain't nothing to brag about. But this must be a new road. When you count 'em singing Blue Moon, you turn me all the way around. And I'm tired of the firelight. I just want you to be forever mine. Forever mine. Oh, when there's nothing I can sing now that ain't been sung before. Oh, but your love is a standout. So gone ahead and take the floor. You had to Jimmy my heart lost, and now I'm stuck in your voodoo. Pick me up, don't ever put me down. Look, I'm tired of the fine line. I just want you to be.
Hi, everyone. Welcome to the 2022 Perinatal HIV Roundtable. We are very, very excited to welcome everyone here. We have a great program, and we're going to go ahead and get started because we have a packed 2 hours. And keep your introductions coming in the chat, please. To make sure everyone is in the correct place, today's topic is updates in breast and chest feeding, parent perspectives and evolving practice, moderated by myself. My name is Leila Pollack. I'm a family physician and the Director of Women and Children's Consultation Services at the National Clinician Consultation Center at UCSF. And my dear colleague, Olivia. Do you want to introduce yourself, Olivia?
Yeah, absolutely. My name is Olivia Ford. I am the editorial director for the Well Project, which I'll introduce our organization just a little bit in a moment. And yeah, just really glad to be here and really glad to get to just hold this space with y'all.
This is just an acknowledgement of our funding. We're very grateful to HRSA for our funding that has helped us to run this roundtable. And a disclaimer that what we present is our views and not the views of DHHS or HRSA. The National Clinician Consultation Center is a free telephone advice service for clinicians, and the Perinatal HIV Hotline is one of our hotlines and services. And we run the roundtable as part of, under the umbrella of the Perinatal HIV Hotline. And I do just want to take the time up front to thank and acknowledge our program manager, Marlisa Warren, who is our wizard behind the scenes, who has really done everything to make this event happen. Marlisa, I don't know if you want to unmute for a second and just say hello.
Hi, everybody. Some of you will get to talk to me later in one of the breakout sessions.
Thank you.
So that's me. So again, I am from the Well Project, and we are currently in our 20th year, an organization just really sort of embedded in the HIV community with a mission to change the course of the HIV/AIDS pandemic through a unique and comprehensive focus on women and girls through across the gender spectrum. And this work, again, I just want to say, is really just at the intersection of so many aspects of what the Well Project does, as will be unpacked sort of further throughout the course of this afternoon together.
And this is our UCSF land acknowledgement. So UCSF as an institution, and many of us who work here at UCSF and at the National Clinician Consultation Center sit on Ramaytush Ohlone land. So we would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding.
And I just want to also share that I'm physically located in East Flatbush, Brooklyn, New York, which is on Lenape land. I'm going to drop a link into the chat as well. Other folks are welcome to, if they do not already know, just share and acknowledge the land on which they are currently physically located. The Well Project is an all remote team. So I myself am in Brooklyn, as is one of my other esteemed colleagues, but other folks are located on all swaths of native land throughout this country and this continent. So thank you so much for sharing where you're currently positioned in the chat, if you wish to. And again, if folks don't know, they can take a look at that, the link that I just put in the chat.
Thank you. Today's agenda, so we are currently doing introductions and housekeeping. We did our land acknowledgement. We're gonna have Judy Levison present an overview of history, research, and guidelines of breast and chest feeding for people with HIV. Then we'll have a panel discussion. We'll have a very short Q&A, and we really hope that you save a lot of your questions and ideas and thoughts for the breakout rooms, because we will have 30 minutes for small group discussion, and then a few minutes to come back to report back what we learned and what we want to continue learning and working on from this. Please use the chat liberally, drop in questions, ideas, thoughts as we go along. And later on, we'll also be sharing an evaluation link that we really would appreciate if everyone would share. And afterwards, we'll share back some notes, some sort of anonymized notes from all the groups so that everyone can get some sense of what happened in all of the different breakouts. We hope that you're able to stay for the whole session. And Olivia just put in a link that has the more detailed bios of all of our amazing panelists, and also just some more information as a reminder about the session today.
So housekeeping, that's me. I really do consider these kind of a set of agreements that we're all kind of going to do our best to adhere to while sharing the space together. And again, you know, as Leela's kind of referred to, this is not just your ordinary webinar. It's really an opportunity to be in community and in conversation around this topic for the time that we're going to be sharing together. So I just really want to remind folks that there are folks with a variety of lived experience in this room, this virtual large circle, and all kind of bring their own area of expertise to this space. I definitely want to encourage folks to avoid jargon, just as some examples of that, say out the full term that you're referring to when you use an acronym alongside the acronym, unpack concepts a bit that may be very specific to your discipline, just things of that nature. That is towards making sure that as many people as possible, hopefully everyone who's in the room, can all be on the same page and completely understand and follow what everyone is saying, so that we can all just increase that level of sharing. I just also want to remind folks to use respectful and person-first language. I will share more about that. This is an area that the Well Project has done quite a bit of work around over many years. Just to share an example of that, which folks may have heard or may not have. We're coming from a lot of different experiences. I mean, just an example of language to be aware of. One that comes up often in provider spaces is use of terms like HIV infected. The language that I would like to put out to use in this room potentially is language that sort of puts the person before they're experiencing the condition that they're living with. So people living with HIV, people with HIV. There are other examples of person-first language, but I just want to put that out there as part of the container for holding space. And just encourage folks to be curious, mindful of the depth and the limits of your knowledge and expertise, and just open to, just the wealth of perspectives and the wealth of expertise that we're all bringing into the space. And of course, as much as you are able, it would be great to be able to see folks' faces if you're able to leave your camera on, at participatory times, if you're able to unmute, so that we can hear your voices. And again, just have that sense of sharing space together, which we are, if virtual, but we are still sort of creating a space together, and all showing up in the ways that we are able. And of course, in the breakouts, come back into if you have any technical difficulties or challenges, just encouraging folks to you can leave and come back to the main room, and there will be someone there to assist you with whatever challenge you may be experiencing. So yeah, just some pieces to make it a little bit smoother as we spend this time together.
Thank you. So I am going to stop share so that Judy can share her own slides and introduce the wonderful Judy Levison. Dr. Levison is an OBGYN at Baylor, where she has cared for many years for women with HIV throughout pregnancy and beyond. And Judy has supported people with HIV who have breastfed for many years, and has been a leader in this field. Thank you, Judy.
Thanks so much, Leela, and thank you to all of you for being here. I'm very briefly going to go over some of the research on breastfeeding among individuals with HIV from the past and where we may be headed. I have no disclosures, and I just want you to know I may use breastfeeding, chest feeding interchangeably. When I say breastfeeding, please also hear chest feeding. And research done in the past on this topic has investigated primarily cisgender women, and results are therefore reported on women. But if I make any errors, give me a little slack. So some brief medical history dating back to the 1990s. Where are we now in terms of perinatal transmission? So once upon a time, prior to antiretroviral therapy, transmission was in the United States was about 25%. Then with AZT during pregnancy and labor, and for the infant after delivery for 6 weeks, in the mid-90s, someone got brave and decided to dare to give AZT to pregnant women, and the transmission dropped to 8%. With ART, meaning combined therapy, multiple drugs, we now are at less than 1%. And if somebody is on antiretroviral therapy at conception, throughout pregnancy, and at delivery with undetectable viral load at all of those points, among 2,500 mother-baby pairs that were studied, there were 0 transmissions. So then comes the question, what's the HIV transmission rate through breastfeeding, and what is the evidence? So before we had antiretrovirals, it was estimated to be about 16%, which was fairly high. So what is it now with antiretroviral therapy? All of the major studies have been done in low resource settings. And I'm just going to walk you through 4 studies briefly, just so you know some of the data that we are relying on as we move forward. First one is the Keisha-Boros study, and that looked at maternal treatment while breastfeeding. Women maintained on triple therapy until cessation of weaning at 20 weeks after birth had a lower risk of transmission to their babies at 12-month follow-up, and that was 5.4%, than women who did not get antiretroviral therapy and whose babies just got a very short course of prophylaxis. So it was about half of where women were not taking anything. So suggesting, yeah, women taking antiretrovirals does help while breastfeeding. This is actually someone who was doing some of the next study in Botswana, and that's the Mabana study. This was maternal treatment while breastfeeding. And here they looked at women on 3 different regimens, up to 6 months of breastfeeding, was associated with 1.1% risk of transmission. They did look at viral loads, but they had some women where they were using viral load less than 400, others less than 50. And you can see that not everybody was meeting this less than 50, which is one of our ideals, to have undetectable viral loads. Then came the BAN trial, and they compared infants on antiretroviral prophylaxis to mothers on full therapy to see, is it better if the mother stays on treatment while breastfeeding, or should we be treating the baby and mother doesn't have to be on treatment? And at 6 months, the cumulative HIV incidence was 1.7% for the infant prophylaxis, 2.9% for the maternal treatment, and 5.7% for basically the control was just baby got a week of prophylaxis. There was no statistical difference between the 1.7% and 2.9%. So it was felt to be pretty equal between infant prophylaxis or maternal treatment, but those were definitely way better than the control. And so as a result of this study, oh, my thing has just stopped. Oh, there we go. Okay, there we go. As a result, WHO in 2010 came out and said, okay, all of you countries, you can decide. You can either treat the baby with antiretrovirals till fully weaned, and they called that option A, or treat the mother with antiretrovirals until the baby was fully weaned. And what happened was that most countries, I think as far as I know all, went for option B and then made it into B+, which was the mother went on antiretrovirals while she was pregnant, kept on it while breastfeeding, and then she stayed on for life. The last study I'll mention is HBTN-046, and that looked at placebo or long-term infant prophylaxis while breastfeeding. And what they found was no difference in HIV acquisition among babies given placebo versus 6 months of nevirapine prophylaxis if the mother was on antiretroviral therapy. So infant prophylaxis decreased babies getting HIV only if the mother was not on antiretroviral therapy. And so many people have seen that have concluded that there's no benefit to prolonged infant prophylaxis if the mother is on antiretroviral therapy. And I'll come back to this as to why this remains a sticking point for many, and understandably. The one other issue that comes up, and I am not a bench scientist, but as this is Judy's interpretation of what the debate is, we know that there's cell-free HIV RNA DNA that appears to correlate with plasma viral loads. So if you do viral loads on breast milk, it's kind of like doing viral loads on blood and just seeing what's floating around in the blood. But even with undetectable plasma viral load and undetectable cell-free RNA DNA, there still remains some cell-associated HIV in breast milk, and that's integrated into CD4 cells. Whether the cell-associated HIV is infectious or as infectious as cell-free HIV is not known. And one study in Canada did one sample of breast milk, and they found the viral load was undetectable, but this cell-associated HIV was found in breast milk. So they felt it was reflective of some latent virus within the CD4 cells. And, you know, talking with some people who do some of this kind of science, they've said we just don't know if it's just little fragments of HIV that are there that aren't going to do anything bad, or whether they could start replicating. So where are we now? So we know 16% transmission via breastfeeding without antiretroviral therapy. With antiretrovirals, initially suggested 1 to 5% transmission, but they weren't strictly correlating with viral load. Viral load often wasn't available. The most recent study that we are leaning on quite a bit is the PROMISE study that was published in 2017. And what they showed is that women who were on antiretrovirals with undetectable viral loads, at least at the time that they were tested, had a 0.3% risk of transmission at 6 months, 0.6% at 12 months. So that's 3 per 1,000 and 6 per 1,000 at 6 and 12 months. So very low, but not zero. And then one other hooker in this whole debate is from the era before we had antiretroviral therapy. So we're talking 1990s. A study was done looking at women who exclusively breastfed compared to women who did mixed feeding. And what mixed feeding was not well defined. So it was breast milk, formula, and maybe solids, which is an issue because baby guts are not ready for solids, or newborn guts certainly are not ready for solids. And they compared that to formula feeding. So formula feeding, there was no transmission. But they found that the exclusive breastfeeding, there was a lower risk of transmission than when people went back and forth. And there are two different theories that are out there as to why. One is that formula and solids are not physiologic for infant guts and may irritate the gut, or some formulas may. Solids definitely do. And then you chase that with breast milk that has HIV in it, and the HIV goes to where there's inflammation in the gut and enters the baby through the portals in the gut. The other theory is that it has to do with the maternal breast, and that is that someone who is intermittently breastfeeding has more engorgement, and where there's engorgement, there's inflammation. Where there's inflammation, there's HIV, and that's how babies are getting exposed to HIV. We really don't know. So some of the challenges going forward, until recently, we had no studies in high resource countries because it had been assumed the lactating parents with HIV would formula feed where formula is accessible, feasible, affordable, safe, and sustainable. We now know also not all of these things hold up in the US. Safe in Flint, Michigan might not be quite the case, and accessible with formula right now suddenly is an issue in the US. So why can't we just rely on the African studies? And the reason is that the conclusions from those studies may not be generalizable. And that means that generalizability is the measure of how useful the results of the study are for a broader group of people or situations. And you don't know if these studies are generalizable until you do similar studies in other populations.
5 minutes, Judy.
Okay, great, thank you. So why doesn't every parent with HIV want to formula feed? And I'll give you just, this is one of the most common scenarios that I see, and we'll talk about some other ones too. 32-year-old woman originally from Nigeria was diagnosed with HIV during her pregnancy, and she communicated that she wanted to breastfeed. She was afraid that not breastfeeding would raise suspicion in her community about her HIV status. If she was seen not putting her baby to breast, it was the equivalent of announcing to her community that she had HIV. And she'd also heard and read so much about breastfeeding being better for her baby and also for her. So she was referred to a local PD HIV specialist who reviewed the risks of transmission via breastfeeding. She was really relieved to be able to hear her concerns or know her concerns had been heard. And she opted to breastfeed for 3 months, both to prove to her community that she didn't have HIV and in response to the public messages that breast is best. She and her baby remained on some form of antiretrovirals while she breastfed, and her baby remained HIV negative. And I think this is just one common example in my practice, but there are women of many other racial and ethnic groups who are expressing a desire to breast and chest feed, as I think you're going to hear in the next hour and a half. So the question comes up regarding breastfeeding, does U equals U? With sexual partners, we can say yes. During pregnancy, we can say yes. And during breastfeeding, we can't say an absolute yes. There still seems to be a small risk, but each individual really has to do their own risk benefit assessment. So this is a snapshot of the US perinatal HIV guidelines. And I will tell you that these are very much in flux right now. Until 2015, there was basically this guideline said no breastfeeding. And 2015, one sentence was added basically saying individuals may face environmental, social, familial, and personal pressures to consider breastfeeding despite the risk of HIV transmission. 2018, a full section on breastfeeding was added. And in 2022, the guidelines are in the process of moving the discussion toward shared decision-making. And we hope by the end of the summer that there will be a new iteration of that. And that is really reflects a lot of finally listening to the community. So who are we here to serve? Who are the guidelines here to serve? And realizing people are going to do what they're going to do, and we need to honor that. There's definitely increased interest in breast and chest feeding in high resource countries. Among 93 US clinicians who were surveyed, 1/3 said they were aware that there were women in their care who had breastfed. In Germany, they looked at 15 treatment centers between 2009 2020 and we're seeing a gradual increase in numbers of women who were breastfeeding. In terms of high resource countries, there's one Canadian series of 3 infants, Baltimore, 10 infants. There's an Italian series of 13 just published this year. And so we really don't have a lot of data. And one of the other complicating things, and it's difficult for every pediatrician that is caught in this, is should the infant be on prophylaxis? So the standard prophylaxis after birth for any baby that's been HIV exposed is 4 to 6 weeks of AZT. Some clinicians will add nothing more than that. Some will add just nevirapine prophylaxis while the baby is breastfeeding. And some clinicians will give full therapy to the baby while the baby is breastfeeding. And we really have no evidence to support anything beyond the 4 weeks, but are we doing what really needs to be done, or are we making ourselves feel better? And I think we don't know the answer to that. So we're right now in the process of gathering, doing a multi-site retrospective chart review. We hope to have our data collected by the end of June. We have 8 to 10 sites with so far 52 infants reported. If we get our last site to finish their data collection, we hope to have 70. And we just ask questions of clinicians. What was the motivation of people who opted to breastfeed? What were the current practices of the OBs, pediatricians, infectious disease clinicians, ranging from how often they checked viral loads or tested the baby, and also what kind of prophylaxis, if any, they gave to the baby? Were there institutional guidelines? How frequently were people monitored? What happened? What was the real life experience, exclusive versus mixed feeding? Were there any situations associated with transmission? We're trying to figure out who are the good candidates for breast chest feeding. Right now, we're saying consistently undetectable viral loads prior to delivery. How often should we be checking viral loads while mother is breastfeeding? How are the pediatricians navigating this prophylaxis for the baby? What happens with mixed feeding? And how do we reach clinicians and parents about changing thoughts on this whole subject? We also wonder about the whole cell-associated versus cell-free HIV. How long must an individual have an undetectable viral load before it's safe to breastfeed? And what are the levels of maternal antiretroviral therapy in breast milk? And is it good or is it not good to have those levels in the breast milk? And we're also curious to hear what you want to know.
Thank you. Thank you, Judy.
Okay, and this is my last slide. So questions about, should we be having a prospective registry of some sort? And I thank you.
Thank you so much.
Absolutely. Dr. Levison, thank you so much for that fantastic presentation. I now have the honor of introducing Greg-Elaine and Ciara Cici-Coven. Greg-Elaine is an associate professor in the Department of Obstetrics and Gynecology at Drexel University College of Medicine in Philadelphia. And Ciara Cici-Coven is program manager at the Well Project and my coworker, colleague, a survivor of HIV for more than a decade and mom to Zion and Zuri.
Hello, everyone.
Hello. I'm so grateful to be here with everyone, and especially, to be able to share a space with Dr. Eileen, who helped me so much through my pregnancy. And to just start to talk about, how important that OB space was for my experience as a woman living with HIV who successfully breastfed for 7 months. We are about 2 weeks outside of weaning, and we have followed everything that was, every person that was there to support us. We have followed, every piece of advice and questioned when we needed to. And I'm so grateful that he was on my team. Dr. Eileen, just from speaking to you before, I want to know just straight off the rip, what made you, like, how did you get into this work? What made you a provider who would support this decision?
Thank you, CC. Well, it was a journey. I think, caring for women living with HIV and in pregnancy for as long as I have, I do remember when it was this idea of you were assumed to just, not nurse, but just use formula. And there was no discussion, actually. And in the way we care for patients, the idea of getting to know you, understanding that people come from such varied backgrounds and have different opinions, I would want to assist you in one of the most natural things that could ever be occur in most of these situations is to nurse. And so the idea of just saying no and be paternalistic and say you can't, and not addressing the issue of what are your desires, what are your cultural beliefs, didn't sit well with me. And so the discussion, we do it with contraception and other things. And it was like, why should we not be discussing this? We sort of ran from it. And I have a great team of people that work with me. And it was really important for us to be able to educate, because that's what we do, and to discuss what we do know about nursing, the challenging conditions, the issues of transmission, what are those things, and to have a dialogue. And, we have 9 months to do it. And we figured, why not have this educational process? And the focus on a multidisciplinary approach was really critical for us to be able to arm you with the most recent information so that you can make the best decision for you and your baby. So that's how. And we had situations in the past where patients, we weren't as supportive in the sense that we didn't have the discussion. And then people were nursing without us knowing it, and not allowing us to be able to help in those decisions, to do it in a way that may be the most effective and reduce the risk. So the idea of having shared decision making, and that's a term that I think is somewhat challenging because I don't think we're trained in doing and having shared decision making. It's really us providing what we know so that you can make the best decision for you and your family.
But then that statement kind of even rubs me the wrong way, because if you tell me that, the risk is less than 1% of me transmitting a virus to my baby, if we're, on medication and everything, but then if I do decide to take that risk, then there could be like some trouble waiting on me on the other side. And that's kind of how I made it to you, because I have been seeing one infectious disease, doctor almost my entire time back in Philadelphia. I've been positive now almost 14 years. So about 10 years of my care had come out of this one entity. And when I got pregnant, because I had been doing so much work with the Well Project, and I had met other people like Heather, and I was actively watching Heather O'Connor breastfeed. And so I'm so excited when I get pregnant. Well, I wasn't so excited to be pregnant, but I was excited that I was going to have to make this decision. And when I got back to them and I'm like, yes, I want to breastfeed. But first you need to change my medicine. There was a whole nother issue because these meds I'm on, or the side of the bottle says I shouldn't be taking it. So I have those thoughts going through my head. And while we're changing my medication, I want to talk to you about breastfeeding. And the responses I got just left me, after that call, I felt so hopeless and like I had run against a wall. So the first response was, oh no, why don't you try donor milk or, a milk bank? Which to me, that left me with only one choice, because I've never had access to a milk bank. I don't know how to get to them. Come to find out, insurance doesn't even cover it. So you're giving me an option that really isn't an option. So then when that didn't work, it was, well, the pediatrician that we work with is known to call DHS on parents that decide to breastfeed while living on with HIV, which was very disheartening, because I have an 11-year-old who I have had also since living with HIV that I've been able to take care of. Like, we're doing great. This is a great child over here. But because of my choice to feed my new baby from my body, that could, get both of my children potentially in the system, very disheartening, and couldn't figure out how a white woman living down south had gotten the option to breastfeed. Then when that didn't work, I was offered, secrecy. Well, if you choose to do this, then you're going to have to be quiet about it. And that's scary. I'm not that, as Dr. Eileen knows, I'm not that type of patient. Like, I'm going to come in, I want to be able to tell you everything that's going on with me so that we can work together to, like, this is my healthcare. This is my healthcare. So when I figured that was the issue, I had to link with an infectious disease provider who would support the decision. Going through the process, I did not see that provider a lot at all, maybe twice. Just ran my blood work, made sure I was undetectable, prescribed my medication. My OB was who was the most important player, for me throughout almost the entirety of the pregnancy until we got closer to labor. And then I got linked with a pediatrician who also supported my decision. I think that it's very important that we are given a choice, like not given a choice. Like, I just need you to support what my decision is. It's not the provider's position to tell me what to do with my life, like, or my babies. I just need you to leave the space open for discussion and choice. That's something that evaded me back in 2010 when I had my first child and led to deep postpartum depression. I mean, talk about somebody sad and who didn't feel like their baby needed them, made me very, very sad. So it was great that I was able to link with Dr. Eileen and his team. I had a social worker and a high-risk nurse, and I get to come to his clinic every week, and just one team to carry me through this whole thing was life-changing. So whatever y'all are doing is a blueprint that I think could be followed by so many others out here.
I agree with you 100% on that. And again, it was a journey. I think we all learned a lot. We learned a lot from you. We have been very supportive and not dismissive of your decision. And I think that is critical. Not everyone has the skill set to be able to do shared decision making. And it sounds a little weird to say shared decision making because it really, it's in my opinion, somewhat of a misnomer. It's us educating and, getting you to a point where you're comfortable with the decision that you're going to make, because ultimately it's your decision. And, being supportive at anything that you choose is really critical, knowing that we always take risk in life all the time. And I understand from the pediatrician standpoint and how some can feel in a different way because they want to protect baby, but you and baby are a unit and rely on each other. So it's really important that we continue to focus on you as a unit. For so long, we were as OBs not as educated and involved in infant feeding issues. And so it's really important to have that dialogue, and you have a whole pregnancy to deal with it and to discuss it. So we take advantage of it. So I'm glad you were really helpful for us as a team. And, we continue to have patients who are deciding to nurse, and many don't. And it's, again, a very personal decision that you have to make. And I'm glad we were there for you.
Thank you. I just got word that we have 5 minutes left. So I think
we do have 5 minutes. Okay, we can keep yapping then. All right.
Yes. That choice part, like, once again, Dr. Ed can let you know that I didn't know up until maybe the month before how I was going to feed this baby. I went back and forth, not sure, but I didn't feel pushed or pressured into one way. And it's something that I really had to unpack, because you're so used to when you get, this virus, that these are the things that you can't do anymore. I can't join certain organizations. I can't work this profession, and I can't feed my baby from my body. But now for that to be turned in a way to now, oh, it can happen and you'll support me, and nobody's out to get me. That was something that it was really hard, and it was on me. And to be completely honest, to have like the responsibility of my health on my own shoulders was something that was new. And unfortunately, there is a new feeling. But in that moment, I felt that. And I got to make the decision. And so by the time I showed up to the hospital, it was already stuff in my charts that let them know that this was what my plan was. We know that, she's living with HIV, but I received lactation support on the 3rd day of the hospital stay. But I finally got it after trying to feed a baby from my body for 2 days almost. But it was phenomenal. And I thank your team so much for the support, my social worker and everything. It's just great. Is there anything else that you have to add?
You've said it the best for me. It makes my heart really feel real great that we have done this, and I'm proud of the team that I work with, because that's really the key. It's not an individual process. It needs, you need a multidisciplinary approach. Everybody needs to be on the same page and be supportive of you. And I think this sort of mindset is growing. And I think, the word gets out that this is what we're doing. This is our approach, and it seems to be successful. Hey, it's a win, and I'm excited.
Yay. And we're done in record time.
Yeah, perfect time. Good.
Thank you so much, Dr. Eileen and Cece. I am just so grateful to hear your stories. And I am going to introduce our next amazing pair. So next we have, next we have Alyssa Crawford, who is from Fort Lauderdale, Florida, and was born with HIV. Alyssa became an advocate at 19 and has continued to be a liaison in the community. She's currently working as the outreach supervisor for the Minority Alliance for Advocating Community Awareness and Action, and is the Community HIV Advisory Group representative for Area 2B. Alyssa gave birth in 2020 and was successful in breastfeeding her child, who maintains a negative HIV status. And she will be joined by Dr. Allison Agwu, who's a professor of pediatrics and internal medicine in the Division of Infectious Diseases at Johns Hopkins University School of Medicine. And I believe congratulations are in order for a recent promotion. She's also a researcher with a goal to decipher, address, and minimize disparities in treatment and outcomes for those living with HIV, and recently was the lead author on a paper of a series of patients who breastfed their babies. And so we are very grateful to have you both here. Thank you.
Thank you. Alyssa, it's great to be in a space with you and everybody here. And we've had an opportunity to speak before, and I was enamored by what you had to say, and I really do want you to share with others. So I'd like to start first with talking about the process for you finding a pediatrician to help support you through breastfeeding your son.
Hello, hi everybody. The day is finally here, and I'm so excited to be a part of this table right here. So again, I'm Alyssa, and my journey in finding my pediatrician or OB. So my OB was my pediatrician. She was able to see me while I was pregnant, Dr. Anna Puga, that many may be familiar with. So she was my OB throughout my pregnancy. I stopped being her patient when I was around 24, and I was so elated that I was able to be back in her care, because she is phenomenal at what she does. And she is the one that offered me the option of breastfeeding, because up until then, I, had all these worries of, stigma and the threats of CPS custody and things like that, as well as the risk of my child becoming infected, because we all know that breast milk is one of the 4 bodily fluids that, carried HIV. So with all those things, that was just a very heavy weight on me. But then when she offered the idea of, or option of being able to breastfeed, it really opened up or create this new wave of hope for me. So here I am.
I remember you made the comment when we spoke before that you had been haunted by the idea that you would not be able to do this. Maybe unpack and share with others what that meant. Was it really the fear of transmission, or what was the haunt for you?
The haunt, just being a perinatal and growing up with it and trying to find myself in the world as it pertains to a status, it really the haunt really came in the idea of knowing at that time or feeling like I was not normal. Like I was unable to truly, properly, or, naturally care for my child, how, someone who's HIV negative would, just the idea of not being or feeling or just being a normal person. That was a major thing for me.
And talk to us a little bit about what the process looked like for you and your baby for, going to the doctors, the follow-up, et cetera. What did that look like and how did that proceed?
Okay, so when I got my healthcare all in South Florida, my prenatal healthcare, everything in South Florida. My numbers were good. I did not get into care until my 6th month of pregnancy. I just took my medication. I stayed on top of my personal blood work numbers and things like that. And I was undetectable throughout the entire process, even when even when I got into actual prenatal care, which is why she even offered me the option of being able to breastfeed because my numbers were good. And so she told me the process of how it be with the baby being on AZT. And, after the 6 weeks, she'll be transferred to, another medication to, just ensure her not, getting HIV in general. And so it was well explained and the process was very smooth, actually. Unfortunately, fortunately, because she was still full term, but she came early. So she came 2.5 weeks early. And by that time, I was in Tallahassee, being in the process of relocating fully to Tallahassee. But my birthing plan was to give birth in South Florida, around Dr. Puga and things like that. So when I was in Tallahassee, and I gave birth here, because I wasn't with Dr. Puga, the doctors in the hospital, they didn't allow me to breastfeed. So, which is what I would like to see more of, more doctors being familiar with this, this becoming normalized in a sense for, the moms that do follow the proper guidelines, who's able to breastfeed. Because in the hospital, I had to actually give my newborn formula, at the time. And that just kind of clashes with with one of the guidelines for a positive moms to breastfeed, which is exclusively breastfeeding and not mixing. So, we started her off with formula and then we went to the breast when I left, so.
What was that? I'm curious what that conversation was like, because we talked a lot about stigma, et cetera. And you said you weren't allowed to, and that triggered me. So what was that conversation that happened in the hospital and how did that?
It was, to me, like, it was a grim feeling, but it was something that, like, I always prepared myself for because, like in the stigma world, we're used to having no's and you can't do this and you're not able to do that, so, Dr. Puga even offering that option to me was a breath of fresh air for me. That was just something totally different. And it was just it was what I needed while I was pregnant with all the hormones and the emotions and everything like that. That is definitely like what I needed to continue having a healthy pregnancy. So when that came, it was a blow, but because of the confidence of having a medical provider giving me that green thumbs, especially someone who is as competent as she is in her field and this being her expertise, I just played that game and I went along the lines of, okay, I'm going to say, I'm abiding to your rules here in your face, in your facility. But when I go home, because I do my own research and I know how to, care for myself and the health of me and my child, that I can, follow the guidelines that I originally put in place with my healthcare provider once I'm home. So my thing was just to minimize CPS, Child Protective Services, being involved. I just did not want that at all. So I allowed, I went with them when it came to giving formula to my kid, because I saw how they were. Everybody's like, oh no, it was just, it was medical stigma, something I'm not unfamiliar with. So
That's one of the things that we oftentimes talk about, in that it's much better to have this open dialogue than to have people really go undercover and do this, right? Having a space where people can say what they need and having the dialogue and the risk benefit in their particular situation, and
Mhm.
with all transparency moving forward versus trying to avoid and being fearful. And so thank you for being honest with that. I think, in our attempts to provide great care, at times we can reinforce and reemphasize the stigma. I'm wondering, we have a lot of pediatricians on the call, and I'm wondering if you had recommendations for them how to interface with a mom with a baby who's wanting to breastfeed. What advice would you have for them? What do you need as part of your team? What do you recommend to them that has worked or didn't work for you with your care with your son?
My biggest thing when it comes to healthcare is competency in general. I'm just very big on, knowing your facts, knowing the most up-to-date material and research as it pertains to making an informed decision, let alone something that you're advising someone to do. Having a personal opinion is a lot different, much different than having actual research back behind it, and research as in that's something that's not outdated, so I guess each one teach one is the thing, my child's pediatrician, I met her when we were in the hospital after I gave birth to her. So they called the ID pediatrician to come to see us. And she asked me who was my pediatrician. And I told her Dr. Puga, Anna Puga. And she was like, oh, wow, that's your doctor? I'm like, yes. And, I knew Dr. Puga was a big deal, but it just was such a empowering and very strong feeling to hear that she was, she used to be in the audience at Dr. Puga's seminars, so that was a very positive feeling. And so again, each one teach one, and really be up to date on what you are suggesting to your patients, because the people that you serve outside of the research, they're people with feelings, and support goes a long ways, especially if it is backed by research and and knowledge, informed decision 360 degrees around.
I asked you this one before, but I'm gonna ask you again. Now, particularly being a young person who was born with HIV yourself, what were your fears as you were going through the process of breastfeeding? Did you have any fears, and what were your fears in terms of?
Not afterwards, no. Once I got the green light from Dr. Puga, the thumbs up to breastfeed, all my fears went away. My nightmares, the things that like hovered over me, that all went out the window. I felt a sense of security, because if CPS was to knock on my door and say, hey, we heard that this is what you're going to do. Well, my actual doctor who specializes in this is the one who approved me to go through this. And she's the one who provide the option for me, because prior to, I just knew I was going to provide formula, so when she asked me, it was like, excuse me? I mean, Dr. Puga, duh, formula, what do you mean I'm going to feed my kid? She's like, oh, you have options. I'm like, I would have never guessed in a million years, I would have never guessed that we get to a day where we, as positive people, get options, like normal people. I mean, we are normal, but, so, yeah.
I guess the last one I asked you advice for, last one for me, and then I hoarded all the questions. So if you have any for me, please give them back. But what's your advice for other women who are interfacing with pediatricians as they navigate breastfeeding for their children? What's your advice?
I suggest doing a lot of your own personal research. When I was pregnant, I did a lot of research in different areas outside of HIV, just because I wanted to be as informed as possible so that I can make the best healthcare decisions for me and my child, especially in such a crucial time. So, like looking at different articles, looking at different news reports, if, something comes up on Google, Facebook ads and things like that, it kind of like, raises a eyebrow. Look further into it beyond just, like what you see. Get experiences from other women, because support goes a long way. So it's not just something that we is like, it just surpasses your friends and your family, like you can get support. Like me and Sierra, we've never met in person, but we've gained, we've created this very strong support team for one another as other, advocates in the field and just other women and people in general who are supportive of our means and measures. So like, it is very beautiful, it's phenomenal. And one thing I would want is that healthcare providers continue to strengthen their umbrellas and their circles and connections, because each one teach one. And I can't stress that enough, so. Yeah, and so lactation support, I wrote this little note here. CC mentioned lactation support, and I didn't even have anyone walk into my room and tell me about, lactation or anything like that. But again, I know they said that, they in Tallahassee, their recommendations is that we do not breastfeed at all, but with some of the ID specialists there in town, I would have thought that some people probably would have known about this arena, but unfortunately not. And it's a fortunate thing that we have this table going on right now.
We got the 5-minute signal, so I'm not going to ask another question.
What got you interested in it actually? Because I'm just now learning that there's some, other practitioners that's as into this, new wave of hope as Dr. Pulga, as the few of the women that I've known that have breastfed here in the States, and then as well as Sierra's awesome physician as well. Like, what got you involved?
Yeah, I got to answer this one. I'll take an extra minute. So, having been a provider for a long time, I certainly remember giving the very hard line, do not breastfeed. And I always say this, I feel like I have been part of some women's trauma as they even thought about the idea, particularly women who had breastfed their first babies and then in other parts of the world, and then shutting them down and, giving advice, but such strong advice that they left sort of with the idea and the impression they could never do this. And then when things like Promise and things started to happen, I started to ask women about what it felt like and the waterworks that happened when they reflected on the discussions that told them they could not breastfeed and what it meant to them about them being tainted and harmful to their babies. And what it did to their mental health made me say, we need to be thinking about this in a different way. So that's what got me there. It's the women that I've cared for and their children. And so, not wanting to be part of people's trauma, wanting to meet people where they are literally and to get to a different place. So that's it.
That's awesome. I'm hoping that because HIV is no longer looked at as a terminal but chronic illness, I'm hoping that kind of like opens up the mind frame for other practitioners to actually want to dive into this aspect of, women or people carrying HIV as well as wanting to, breast or chest feed. Thank you.
Thank you all so much for just sharing your experiences. It's wonderful to hear your voices. And I now have the honor again to intro our next pair, Catherine Hansons and Antoinette Jones. Catherine Hansons is an executive director and founder of the Center for HIV Law and Policy and has been active in HIV legal and policy issues since 1984. And Antoinette Jones began her work with HIV advocacy in her early 20s. She identifies as a vertical woman living with HIV, meaning she has been living with HIV since birth. Take it away.
Hi, can y'all hear me?
Hi, Antoinette.
Awesome. Hi, Catherine. How are you doing?
Nice to see you from the chest up again.
Yes, I'm so happy to be
Each other's
here.
bottom halves.
Yeah, I'm so happy to be here. I feel like our conversation is a little bit different because you're not a medical provider, but you're a lawyer, right?
I am.
So I feel like ours can definitely shape things differently for people who are like in the comments asking about like CPS and like the fears that come with that and the stigma and everything that comes along with that. So I don't know if you wanted to share first, like just a little bit of like your experience of working with people living with HIV, who are like giving birth to children, who are seeking breastfeeding, who are wanting to breastfeed, and who just need overall legal guidance and protection. Yeah.
Well, I'll say a little bit about that. I mean, since I've been doing this for so long, I'm sure nobody wants to have to sit through all of that, but I don't for sure. But I do. I think it's really interesting. I was scrolling just a moment ago to see how many men had joined this of the 155 participants, and not that many. I think it's really interesting. I'd like to hear after the webinar is over how many of the 165 or however many people are on this are actually men. And to me, that is an ongoing symptom of the problem that I think women living with HIV and I, as an attorney representing them, have seen since the very beginning. If it's something that affects women, then it is not a priority. You know, I worry really about, I'm very worried about what's happening at the Supreme Court level. And just very quickly, there have been cases, and in cases where I was representing women, where courts have said that, you know, for a woman living with HIV to decide either not to take antiretrovirals when she's pregnant, or you know, particularly on that, was not neglect or abuse, because this affected her right to privacy, right? And also that courts have seen that, recognize that women have a fundamental right to be parents, and that only in extreme situations should the state be able to step in. And one of the things that is at the core of what we think is going to come out of the Supreme Court is a very, very different view about privacy and personal autonomy when it comes to decision making. Some of the cases that I did back in the past had to do with the fact that state laws did not recognize a fetus as a human being. And that is likely how that line is going to be drawn, is going to be very different. And so I do think that the risk of interventions may go up. At the same time, I think, you know, what Alyssa and Cece were talking about, and Dr. Agwu and Dr. Elaine, those are the keys right there. I mean, I really do think that you know, maybe the most important thing I could say is to echo what was said about the real importance of pediatricians, women's healthcare providers being advocates for the women that they're serving, because that is going to be a very, very important source of protection, probably even more than lawyers. And I'm wondering you know, for you, I'm wondering what you were thinking when you were facing some of your own issues, Antoinette. What were the kinds of, like, did you ever feel like a lawyer would have been helpful? And if so, when, and what kinds of counseling was available to you? Like when you were thinking about, okay, living with HIV, pregnant, what kind of help did you feel like you needed, and was it there?
Right. So for me, I had my baby 10 months ago. So in August, and I was told, like, just don't tell the OB side, like wherever you're giving birth that you plan to breastfeed. I had a full and great support from, you know, my pediatrician, who communicated with my infectious disease, and they all communicated greatly with OB care. But it was just that point where it was like, if you are planning on breastfeeding, which we know you are, just don't tell the people who are doing your birthing. And the reason for that was because of the fear. And you're right, Catherine, like I would have loved for no fear, for it to be more so like my pediatrician saying, like, forget them, forget what they have to say, I got your back, you know, like I'm here for you when you need me, just call me if anybody tries to give you any problems. And that is like the first step. And then if that's when I would have loved to see or have the support of a lawyer come in and just be like, yeah, she's making this decision and we are here to protect her and her rights to privacy and her bodily autonomy, and knowing that she is well taken care of by this care team. She takes care of herself, and this is actually going to be beneficial for her and her baby. And that's not what I got. So I had to give my baby formula from the hospital at first, and she didn't respond really well to it. And then once we got home, because my milk didn't come in right away, I did receive suggestions from my pediatrician of, like Cece said, as far as donated milk or purchasing milk from milk banks. And that's not accessible for a young Black woman living with HIV who's not making millions of dollars, because breast milk, chest milk is actually very expensive. And just, they sell it by like, you know, a certain number of bottles that they feel like will be just enough, or ounces that they feel like would be just enough for your child, not knowing that some children eat more than other children, some children eat less. So having to pay at least, I think it would have been at least like $500 to $1,000 for 14 bottles would not have been enough for my child, knowing the way that she eats now. But that was not accessible for somebody like me. So I did end up tapping into some mommy groups and finding out that there were groups who donate breast milk, and just like doing more research around that and connecting with somebody who was like genuinely helpful. Because and I just went on those groups and shared my story. I was just like, look, I'm a person living with HIV and I'm having just a little challenge, you know, chest feeding, breastfeeding right now. And I would love for someone who can support me for these couple of weeks while I produce milk. And I had somebody who like came to me and her child, and this is like really sentimental to me, because her child was in NICU fighting for their lives, and she was an overproducer and was able to share her milk with me. And I was just like, she really like, our stories, both of our stories was like touching. And you know, she had to deal with a lot of stigma because she went through IVF and all types of different things, but it was like we were able to connect on that level, and just, you know, and my child was able to benefit because of her. And then once my milk came in, you know, I was just so grateful for that. But that's just a little bit about me.
Antoinette, I remember when we spoke before that you mentioned that you were within reach, almost literally, of lawyers. But I don't think you wound up sort of reaching out there. And I wonder if you could talk a little bit about why. If you might, is that okay?
Yeah, I think a lot of it has to do with what Alyssa said, as far as like internal stigma plays a huge role, and just that initial like don't tell nobody kind of like sets the mark for like anything that you do after that. So if I'm not, even though like for me, a lactation specialist came into my room and asked me if I needed assistance, in the back of my mind, I'm like, don't tell nobody. So it's like, I definitely needed that assistance, but I'm not about to tell you that, because you're not about to call CPS on me. And it was the same, being around many lawyers who work in the HIV field, knowing many lawyers, but knowing like, at what expense am I going to reach out to you and ask you for support? And are you actually going to fulfill the support that I need? Because in some instance, I need support in like a little monetary way. Like I can't pay you the big lawyer bucks, you know, but and what does that look like, you know? So that's me.
Yeah, I think I can totally understand that, because I do think that women's experience around their pregnancies and their responsibilities has told all of us that you can't really rely even on other HIV advocates to support your decision on this, because there is a lot of oh, I don't know, whether it's patriarchy or a variety of other things that, that get built into that. I don't think you can always be absolutely confident that you're going to get the kind of support you need, whether it's legal or not. And I do think, I mean, I also hear you saying like it would be handy maybe sometime to have a lawyer. And I think, having a lawyer who is like, I don't know, the mace can in your back pocket, if absolutely needed, but not at all where you should have to begin, is maybe the way to think about it. And what you're talking about, Alyssa's experience, Cece's experience, says it's a couple of things. First, that you don't actually need a lawyer if you have providers and a network of other people who will support you and, make sure that what you're trying to do is absolutely legitimate. And you're right, because you're doing it for yourself and for your newborn. And that should always be the starting assumption. And the lawyer for when that all doesn't work out that way. But
I know they have, just diving into this bans on our bodies and this abortion thing. I know there is organizations, lawyer organizations, if, when, how, who have reach out to us if this happens to you. And if we had something like that for people who are living with HIV, who are breast and chest feeding, if somebody comes at you and threatens you for this, reach out to us immediately, or here are some talking points that you can use if somebody tries to threaten you, because it's not just a threat sometimes. We've seen people who have experience of CPS just barging into their hospital rooms, and taking their children, taking their child before they even leave. We've seen this, especially on Black and brown bodies. And it's it's just a gap with we know that this is not legal. We know that this is not okay, but not even who do we call? Because sometimes we don't need to call, but what are the tools that we should have so that we know that we can tell somebody, excuse me, that's not okay. And you're not about to come in here and invade my home and my space. And this is who I'm about to call, now, because not all the time do we want to call the police.
Yeah, absolutely. Well, and who triggers those calls, do you think, Antoinette? I mean, in terms of, Child Protective Services bursting into your room. I mean, it's not it's usually a care provider, right? It's a social service person or a doctor. So they can be both heaven sent and the devil, right? I mean, depending on the role that they play. But you mentioned something that it seems such a brilliant idea, but also part of the point, why don't HIV service organizations that have, certainly those that have a legal department or legal services organizations, why don't they have something very specific for parents who are at risk of having their children taken away from them or having their choices there? Why don't we see that? We see things around housing, very important, employment, very important. It's not that those other things are important, but it's hard to think of many places that treat that kind of thing as an absolute priority, because it's got to be true, right? And HIV service organizations, that there are women living with HIV thinking about parenting. I mean, that was you, right?
All my life.
Yep. And so did your organization have any kind of any of our employees or women, people living with HIV who are thinking of getting pregnant or want to breastfeed or chest feed? I mean,
I don't think it was even a conversation, because it wasn't happening and it wasn't something that I even wanted to talk to people about. I just literally found a network of, I found a network of other parents who were living with HIV, the Milky Mamas movement.
And I felt like that was enough. Like anything that I've had conversations with my providers around, I went back to that group and was like, is this accurate? Is this like correct? How do y'all feel about this? And then I was going off of the feedback that they were giving to other folks. And thank everybody who's on this call who plays a role and a part into that group, because it really benefited me and my decision making, and I know so many other people. But yeah, I think it should be like, if you are a HIV servicing organization and you do house pregnant people who work there, you know, it should look a little bit different. The protections, the centering, the type of care, like all around care, because that does come from your job as well, that they need. And especially when you start getting into like the breast and chest feeding and having to pump at work or having to pump at home, you know, and what that looks like. And are you well? Are you mentally okay? Can you perform this job duty? Like things like that. So
Yeah.
I think it's definitely a conversation that we're going to have for another day, because it's so deep.
Absolutely. I hate to stop you all in this really dynamic conversation. We could go on and on. Most definitely, I want to make sure that we get to have a little bit of Q&A before we go into the breakouts. But thank you both so much for your experiences, expertise, and just for your voices. Really appreciate you so much.
Oh, thank y'all.
Absolutely. Absolutely. We have a few questions in the chat. Leela, did you have anything you wanted to add before we kind of jump in? No? Okay. First question actually is from Catherine Ansons. And I think that it was for Judy. It came up during Dr. Levinson's presentation, really talking about the difference between undetectable, i.e. 50 copies of virus, and the level of virus implicated in transmission. If Dr. Levison, you're in a position to come off, and also just so you know, the next question is actually for you as well, Dr. Levison. So just spoiler.
Okay. Well, I think we just know that transmission, whether it be sexually, whether it be during pregnancy, and it appears also during breastfeeding, is correlated with viral loads. So, but the question is at what level? And so we, at the minimum, we want to see completely undetectable viral load for an extended period of time, but that's still the area where we are not 100% sure that you can't transmit. And maybe because of these cells that are hiding inside CD4 cells in the breast tissue, breast milk. And so we just don't know. But definitely, yeah, the less virus in the bloodstream, the safer it is. But yeah. Yeah, and Dr. Agha was saying U equals U considers it less than 200. Okay, and so less than 200 is sort of the international definition, but yeah, we just don't know. Yeah. And the other question, what was that about the guidelines?
Yes, related. Are you able to comment on what changes we're expecting to see?
Yeah, and so I think some of the comments that have been made are being addressed, that taking the language from basically, you know, formula feeding is the way, and turning it into more of a need to discuss infant feeding with each mom. And I mean, I've already changed my language. I used to say, in the United States, we recommend formula feeding. Is that an issue for you? And now I ask, and what are your thoughts about infant feeding? So, and that has been, so it's that kind of a switch. And I will say that I'm really grateful to CDC for people at CDC being supportive of the guidelines being more inclusive. And CDC is going to be referring there, instead of having their own set of guidelines, will be referring to the perinatal guidelines, the DHHS set. And the other comment that people have made is about child protective services, where that also we now have a section saying there is no role for child protective services when it comes to this. And that was not stated before. So those are two, I think, gives you two examples of changes.
Thank you so much. Excellent. There were one or two other questions. I think that we're going to allow folks to discuss those in their groups in their smaller groups. And there were definitely some really great comments as well in the chat, and definitely encourage folks to continue to interact in that way. And yeah, thank you so much for those insights, especially the piece about CPS that came up a few times. And now I believe that we are going into breakout rooms. This is always what gets a little exciting. Is there anything that anyone needs to come off mute and say about that before we all start getting funneled in there?
I am going to just post the questions that your facilitators will be talking you through in the chat, just so everyone can see them as well. And I really do encourage, like Olivia said, there are so many amazing questions and comments in the chat. And so we hope that that chat conversation can continue in the breakout rooms as well. And Marlisa, is there anything else
I'm going to open the breakout rooms. If you feel like you're lost or you somehow don't make it into a breakout room, hang tight. We've got people in the main room who will help get you to where you need to be. And you can just select the join breakout room pop-up.
That's snatched back.
No, I don't know who else was in mid-sentence, but
Me.
Excellent.
I think we all were. I think they say
Yeah,
it's
I
10
think we all
seconds, but
were.
it's more like 5.
Yes.
I'm looking and it's counting down. I'm like, I still have 3 or 4 more seconds.
Hope
think
that
every
came
group
through. That's
had that problem.
well, I'm glad that that hopefully means that there were lively and
yeah.
wonderful discussions going on.
Yes, there were.
We want to respect everyone's time to wrap up in 7 minutes. And so Olivia, you want to?
Sure. Yeah, just again, if a couple of the facilitators or even folks who we'll stick with facilitators now because we don't have very much time. But if there's kind of one takeaway from your group that you want to come off mute and share, and we definitely invite everyone who has anything that they'd like to share to just drop it in the chat, and share in that way. So yeah, facilitators. I see a couple people coming off mute. Dr. Levison.
Sure. I hope I'm not misspeaking for the group, but just the need for more information on how to do the pediatrics piece and the pros and cons of continuing prophylaxis for babies beyond 4 to 6 weeks, a need for just some publication of experiences and maybe even like what are some of the agreements that some places are using. And we found out in the UK, there's a pregnancy database for all pregnant women with HIV, and they're now starting to ask breastfeeding questions, and the clinician fills it out a little bit like the APR. And it's just done. Like, yeah, people fill it out. So I like that idea. I'll stop there.
Yes, that's brilliant.
Wondering if I could go because I have to transition to the car. So I think we had a dynamic group from all over, including Bola from Nigeria, people from above the border up north. And I think what was really neat in our group is definitely the ask for guidelines and recommendations on how to do this. So even with the data that we have to just highlight things, but also acknowledging some of the tension that we still are not sure, right? Not 100% sure, and people own that. I think one of the things that I think I took away was there still needs to be not a push all the way, everybody should breastfeed. And I think that's not what we're saying, but it's about being open for options and for a woman and a person who's wanting to breast or chest feed to be able to express however they want to do it and to be supported in whatever the decision is.
Indeed, absolutely. Let's see, Cece, I see your hand.
Okay, not sure if I was next, but from our group, from the prompt, it was definitely more data and stories, not necessarily like separating those out, but more of both would be something that people would appreciate. People were interested in like a list of pediatricians who would be like breastfeeding friendly for folks who are living with HIV. So that's why I was putting your name in the chat, your email, Olivia. So that's forward@thewellproject.org. We have an infant feeding listserv. If you're interested to learn more information and to stay on top of that, we are kind of a step ahead there. And I think those were the biggest takeaways from our.
Excellent. Awesome. Thank you. Let's see. I've got Deb, Chris, and then Krista. Oh, Deb, Chris, Christine, and Krista.
I'll be brief. Hi, everyone. It was so great to meet with my group and to see everyone here. And I would just say there was a general thirst for resources. And what I had said is that we will collect resources, and maybe we can figure out a way of hosting it on a website or having some centralized bank of resources for people to access.
Oh, brilliant. So Chris, and then Christine, and then Theodore.
So one of the overarching themes that kind of resonated with our group was the importance of having the entire care team on board with whatever decision the woman made. And in an effort to support that, people really echoed what Marlisa wrote in the chat, which is that the guidelines are really, really important. And if we can have language in the guidelines that support these decisions, it will go a long way to getting the entire care team on board.
And similar to that, we also we're reminding ourselves also that, like, we often think about the provider teams, the parent and the baby side, but also to remember that all the nurses too that care for both of those patients on either end. And sometimes when the baby needs to be readmitted, to widen our sort of definition of who the care team was. And then besides and just an additional specific thing for guidelines, for those of you on guidelines committee, that putting a specific line in there about CPS referral, and that in these circumstances that it is not something that is recommended or helpful, just because I think around the country people still will call the hotline and have a lot of questions and angst about that. And then just a little reminder with all of the discussion, that reminder that we're not there to make the decisions for the patients, but really just to provide guidance and to hand that over to the people that we are serving.
Absolutely. Thank you. Ted, and then Krista.
So I think we had a great, really fantastic group with they came from a lot of different perspectives. But I think we ended on some themes that people have just recognized. I think one being basically finding ways to equalize the kind of the balance of power between providers and patients, and providing a safe, non-judgmental space to make that informed decision. And I think kind of kept coming back to kind of more information, making sure that patients have information, make sure that providers have information. It was a lot about just keep getting people up to date with the current knowledge. I'll pass it off since other points were already mentioned to Krista, I guess.
Thank you. So I'm just going to quickly add one additional point off to the communication between the care provider team and network that it was Finn brought up, and we were talking about the fact that we may need to provide like really specific tools when hearing about like how one provider was afraid to talk to the other provider and say, don't talk to this provider. Like, how do providers speak to each other and advocate, you know, in that setting? So giving them actual communication tools to kind of have those conversations amongst the care team, because that may not be something that they have the skill to do. So just to keep that in the loop, and also like, let's, you know, we're talking about like in your hospital system or within the network, within your community, but like, let's also include CPS in those discussions, you know, to kind of make sure that they are not excluded from that team. Thank you, everyone.
Absolutely.
Yeah, can I, so pretty much most of the focus was on resources in our discussion a lot, was that people were in need of resources, and the focus on the guidelines, how important people utilize the guidelines was pretty impressive for me. And if the feeling that if they're not following the guidelines because they're funded, there's going to be some backlash was really interesting to hear. That you know, not understanding that guidelines are, you know, there, and the level of information and all the other stuff that goes along with each of the recommendations was not necessarily being looked at, and the fear that you'll get in trouble if you don't follow the guidelines because you're funded was really significant. So I think that re-educating people to understand that, and also having better, you know, language in the guidelines is so much needed because of it. So yeah, that's where we spend a lot of time with.
That's a huge one. All right, I know that we are 2 minutes past time, which isn't too much, but it's still, I know.
Yeah, thank you. I just thank you to everyone. Thank you so much to our panelists for sharing your stories and your time and your expertise. I learned a lot and was very emotional listening to your stories, which I saw in the comments as well. I'm very moved. And thank you to everyone, to our facilitators, to our note takers. Thank you so much to Krista Martell and to Marlisa Warren as leaders of our teams in the background, helping us in making this happen. And Krista put a link in the chat, and we'll share more resources afterwards as well. But the Well Project has been compiling resources on this, and we do need more, which all of us can hopefully be part of generating. You can email Olivia to join the HIV and infant feed listserv. You can email Marlisa to join the Repro ID listserv. And some more information here as well. Here are all of our lines at the National Clinician Consultation Center. Call us, use us. We can be a support and also a network to other people around you. And we really look forward to this, to having more conversations about this. I'll put the evaluation link in the chat as well. Please complete that. It really helps us. Does anyone have anything else they want to say in closing?
I'd like to say something. I just want to say thank you to everyone and great job, Dr. Pollack, Sierra, Miss Ford, everybody that had something to do with this, especially the backbone behind it all, the planning meetings, even the ones that was even before me. I'm so proud of you all. Very good job. Excellent work, everyone. Absolutely.
You women give me hope. Seriously, it really does. You really do, all of you.
Same here. Thank you.
Yeah, this whole
everyone.
entire thing, that's the word I would use to describe this whole thing right here. This is hope.
Mhm. There's not a vulnerable woman on this call.
Got each other's
I am
back.
so full of gratitude. Thank you.
Yeah,
Well,
that's
we'll
amazing.
play some music to see everyone out, and feel free to join in the chat, and please follow up with us.
Dr. Pollack, will we have access to all of this?
Yes,
Like everything that was in the chat? Like the questions, the resources that they posted?
Yeah,
I grabbed it, Leila.
Oh, great.
Yeah.
Yes, we will be sharing we'll be sending out an email with kind of compiled notes. And we'll kind of compile stuff that was shared in the chat as well. We'll see if we can try to answer some of those questions.
Will Dr. Levinson presentation be included?
Yes, and we'll have a recording. Yeah, absolutely. Yeah.
Okay, thank you. I'm done.
Yeah, no, never be done.
Thank you so much. Nice to see you all.
Thank
and great
you.
work.
Everybody take
see
care.
you
Glad to be a
guys.
part of it.
Thank you.
Yeah,
I don't want to
everyone,
leave.
thank you so much. I know, exactly. The after party.
I'll be the last woman standing.
When I move my body just like this, I don't know why, but I feel like freedom. I hear a song that takes me back, and I